Okay, so I'm going to talk just about a few things, and please, if you want to stop me at any stage, and because I'm not making any sense, then just do so. Just yell out, and I'll try and be clearer. So I'm going to talk about who we are, what we do, and a final sort of question, which is what's it all about? And when we talk about ourselves, really, we're a network, we're a partnership of different things. One is the clinical teams around the two cancer networks across Yorkshire and Humberside. A centralised diagnostic service where we diagnose blood cancers, and we're very lucky to have probably what is the best diagnostic service for blood malignancies in the world in HMDS in Leeds. And a great alliance with an academic department in York that really makes our research make sense. We cover a population of about 3.6 million people across a large bit of Yorkshire. And one of the great things about that is people come to Yorkshire and they love living in Yorkshire, and so they don't move away. So it means we have a static population that doesn't change, and that makes it really good for studying a whole population of people and finding out what happens to them. And then along with those three core bits of our partnership, there are two other vital bits. There are supporters, and in particular LLR, who give us the money that we need in order to function. Without that, we would be nothing. And then more importantly even than that is our patients. Partly our patients because that's what generates the data. Without the patients giving us the data, without you being willing for us to utilise that data, we wouldn't have anything to work with. And partly our patient partners, as you are, that give us a whole extra spectrum of things that we can look at. So what do? We identify every single patient across our population that gets diagnosed with a blood cancer. And that's really important, to have that whole population of people. And we're actually really good at it. We miss virtually nobody. And we have lots of ways of checking that we do that. And then we collect an awful lot of data on all of those people. So we know about their diagnosis, when they were diagnosed, what exactly their diagnosis was. We know exactly what treatment they've had, no matter how many times they've been treated, and we know how well they've done with each of those treatments. So we have a whole load of information on every single patient in our area who gets diagnosed with a blood cancer. And our aim is to use that data to improve the care of all of our patients. That's what we're here to do. And we get data from lots and lots of different sources, and they're all on this wheel here. So we get all the sort of diagnostic data from HMDS that tells us exactly what the cancer is that we're dealing with. And we're lucky, as I said earlier, with HMDS, they can do some really technical stuff that tells us in great detail exactly what's going wrong in the particular cancer you have. We sort of monitor lots of samples through your treatment, so we know how you're responding to therapy. And then we get all the information from the medical records about exactly what's happened to you, how long you've been in hospital, how you've responded to treatment, how the treatment may have affected you in different ways. We get lots of data, national data on social class, where people live, when they've been into hospitals in other parts of the country or access their GP. And then we get information from you, sometimes by asking you questions, sometimes by sending out quality of life surveys to you. So a whole source of information. And we can use those things to do a lot of different things. So this epidemiology is describing the patterns of disease. And it may seem that, you'd think we would know this sort of thing and would have known it for years. But actually, until you collect data from a whole population, you can't possibly know what the real pattern of disease is. And you often miss out whole groups of people. We can see how well people do, how well people survive with their disease. We can try and think about what might be causing the disease by seeing if certain people are affected with it more than others. We can map up very detailed pathways about what happens from patients from the time that they're diagnosed right through until they finish their treatment and being cured, or unfortunately if they don't survive their disease. And we know what's happened every step of the way. And that enables us to look at what we're actually spending, what resource we're putting into that in terms of people, in terms of the finance that we have to spend, and also what we're asking of you as patients to go through in order to have that treatment. And then we're also able to audit what we do so that we can make sure that all of the hospitals around the region are providing you with as good a quality of treatment as they can. So we end up with masses and masses of data. So this is between 2004 when we started and the end of last year. Nearly 19,000 patients, and it will be 20,000 now. Now that is an enormous data set. And this just gives the spread of ages of those diagnoses. So we've got tiny, tiny babies, up to people of 100 years old being diagnosed with haematological cancers. And as you can see, most people are relatively old. And that's really important because trials are really vital to work out what drugs we need to use. And Pete's talked about that. But often, older people don't get access to those trials. So to understand what happens to them when they're treated, we need to have the population data. And the other thing that's unique about us is that we're able to look at what's happening across the whole of the pathway. So traditionally, research looks at this bit. It looks at what's happening with the treatment and a little bit of short-time follow-up to see how effective that treatment's been. Again, vital to improve the drugs that we use. But we're able to get data about what happened before you came to hospital by talking to you about what symptoms you had. So we can start to think about when the disease might have started. And we're able to follow you all the way through all of your treatments. Some treatments that may have been in trials, some treatments you may have later that aren't in trials. And right through, if unfortunately you die, to when that happens and what support people got at that stage. So we can map the whole pathway. And that means we can start to do things, and some of these are on the wall outside, is produce really detailed maps of what happens to individual patients. So this is just one patient's story who was diagnosed here with a lymphoma, and we know they had a scan done, another scan here, had some chemotherapy here, then they were watched for a bit, had some more chemotherapy, more scans, a transplant, some blood products given to them, transfusions, watched again for a bit, disease comes back, another course of treatment, more treatment with blood products, and eventually, unfortunately, dying from their disease. But we know then exactly what's happened to that person all the way through their treatment, how many days they've spent in hospital, what we've done to them, what problems they've had. And that's just a wealth of information that we can then use. So what's it all about? Well, as a doctor, what I want to do is make people better. That's probably what, when I was small and decided I wanted to be a doctor, that was in my head. That's what I want to do. I want to come in and make people well. I'm a bit wiser now, and I know that that doesn't always happen. I wish it did. We're working towards making it happen, but it doesn't always happen. And for the people I can't always make better, I want to make sure that they have the best quality of life that they can. And for me as an individual, as a doctor, it's really important that I try and give you the best treatment for you as a person, not the best treatment for a whole group of people, but what's right for you. So that's what's important to me. And I've tried to think about what's important for you as a patient, and this is the best I can do, and you may well tell me it's different, but I think you generally want to get better as well. I think you want to get the most out of your life, and so you want the treatment that enables you to do that. So you need the treatment that's right for you. And I think you want me as a doctor to be honest with you about what's going to happen to you. You want to have choices in your treatment, and you want to get some control back in your life, because when you get diagnosed with a cancer, it feels like everything is out of your control and you're just being pushed through a system. And I'm sure that you want to have some of that control back. Ooh. That seems like it ought to be quite easy. Those things are quite similar between what I want and what you want. But actually, it's really quite difficult. And I apologise for having lots of lines, but I'll try and take you through what I'm going to say here. So this is a graph, and up here is people alive, proportion of people who are alive, okay? So nobody alive here, everybody alive here. And this is time along the bottom. And we're starting off at the beginning of people's treatments. And these are real survival curves, but they could be for lots of different things. So say we're on this top curve, this blue curve. At the end of the day, over half the people are surviving. They're cured of their disease. The curve is flat and nobody's dropping off it. So they're all doing fine. So you'd think that having a decision or a discussion about this sort of treatment, you know, if we give you this treatment, it's pretty effective. Over half of you are going to survive at the end of the day. That seems like a reasonably simple conversation to have. The other end of the spectrum, this line here, drops like a stone, and at the end of the day, there isn't anybody that's alive. So this is a disease that we're really not very good at treating. We haven't got much to offer, and actually it might be quite easy to have a discussion and say, really, there isn't anything that we can do for you, and then get into that difficult conversation about how we might best support you. But then it starts to get a lot more complicated. So say this graph here, still not very good, lots of people dying very quickly, many people dead within 3 months, half people have died very soon. But some people are living quite a lot longer with their disease, and in this graph even more. So how do you make the decision? If the treatment's really easy, if it's just taking a tablet, if it's not going to upset your life very much, it might be really easy to say, okay, I'll take the risk this treatment's may not help me, but it's simple to have, so I can have it at home and it doesn't bother me, so I'll have a go at that. If the treatment's really hard and means you're going to spend a lot of time in hospital, then you might not want to do that. But it depends on you. So if you're old and you've got other problems with your health, you might think that embarking on that treatment might not be the best thing for you. If you were 30 years old and you had 2 young children, you might think the chance of actually being able to live for another couple of years was the most important thing that you could possibly have. And so that would be the right treatment for you. So to have that conversation, for you to know what the right thing for you to do is actually really complicated. And you go back to this graph at the top, which looked easier. Well, say we could work out which of the patients would do well and which of the patients wouldn't do well. If we knew exactly which patients would do well, maybe we should be having a conversation about them not needing to start treatment just yet. Or maybe the treatment they have should be reduced so they don't get so many side effects or long-term problems with the treatment. And the people here who we know we're going to do badly, maybe they should have a much more aggressive type of treatment that might be harder to take. So even something that looks like it might be straightforward could actually be really difficult. And it's getting worse all the time. It's absolutely brilliant, as Pete said, that every day, almost every day, there's a new drug to treat cancers. That really helps us to have options, really helps us to think of new ways that we might be able to cure people's disease. But all those options make the treatment decisions more complicated. The diagnostic techniques we use get better all the time. So we're able to tell more and more about what's happening inside your individual cancer, what's changed in the genetics that drive that cancer. And we have drugs that can target different bits of that. So that gets more complicated as well. And that means that your pathway as a patient might in the past have been really quite simple, now might be really, really complicated. There might be lots of different choices about what treatment you start on, what order you have them in. You might go through 4, 5, 6, 7 rounds of treatment through the journey of your cancer. So that's really complicated. And on top of that, as you all know, the amount of money that we have to spend is really limited. And that makes it hard to make choices as well. So I put them on there, choices, 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 decisions, decisions. And sometimes I sit in the clinic and I almost feel like I want to scream, because how do I get that message across? How do I make sure you're getting the right treatment? And I'm sure that you must feel like screaming sometimes as well. We think we can help with that. We think we can make this better. We think that we can use the diagnostic information that we've got on our outcome data that we've got to accurately predict how people will do. So we'll have a much better idea about how you, when you come to us with your cancer, might actually end up doing and how you might respond to different treatments. We can use the pathways that we've got to work out what the effects of the different treatments might be for you. So we could tell you how much time you might spend in hospital, how many problems you might get with that therapy, how well you do at the end of the day. And using those things together, we can hopefully design tools which will allow us to help you to make choices and help the doctor to help you to make the right choice for you. But there's no way that we can do that by ourselves, because giving this information is really difficult. It's really hard to know exactly what you want to know, what you need to know to make decisions, and how we should tell it to you. So we need your help to tell us how we do that. And we're going to be coming to you over the coming years to actually ask those sorts of questions. And I'm sorry, but we want even more from you. We want you to tell us what we don't know. Unfortunately, we don't know quite a lot. So this is a graph. It is from a disease. It doesn't matter what it is, but it's a disease where all of those trials have done something really good. So if you look at this graph, this bit is completely flat. Okay? Nothing changing. So if you get on the treatment, you live. That's fantastic. Years ago, the graph for this same disease would have gone straight down here. Now, you get on the treatment and you're cured. But look, 30% of people never get the treatment. They die before they get to having the therapy that would make them better. No clinical trial of a drug can help those people. It will never make that better. But we can look at that with your help, and that's why we asked you about things like symptoms, because we can start to work out how we could diagnose these people earlier and get them on treatment, and hopefully move this line so it was maybe running along here. So we need you to tell us what's happening before we can possibly have any information ourselves. And we know that it takes a really long time for some people to get their cancer diagnosed. And this is some of our data. If you look here with myeloma and diffuse large B-cell lymphoma, Hodgkin's lymphoma, there are some people who are taking 800, 1,000 days from the first time they get a symptom and maybe go to their GP to actually getting diagnosed. And if we could move all of these down so people were being diagnosed quicker, then hopefully we'd be able to get more people to survive. And then there are other things that you could help us to understand that we really don't understand either. So these are curves of two different types of cancer, and the blue lines are people who are in social classes 1 to 3, and the green lines are people in social classes 4 to 5. Now there's no difference in the treatments that these people get, but the outcomes are worse. Now some of that might be due to other diseases, but in this graph, which is actually a disease where the treatment is really, really effective, we can't understand why those curves should be different. So is there something that we're not doing to support some patients to get through their treatment, to make them understand perhaps about how they take their treatment, or are there other things they're doing in their lives that are impacting on the outcomes that they get? And again, there's no way that we can know the answer to that without the information that you can give us. So what's it all about? It's all about all of you. So it's all about the fundraisers in here, because without the funds that you raise, there is no way that we can continue to do the work we do. It's all about the researchers, because we need to keep focused to make sure that we get the most out of this wonderful data that we have. But most of all, it's all about you as patients, because we need you to tell us what we don't know, and we need you to help us to work out the best ways to communicate between doctors and patients so people get the right treatment for them every time they come to the clinic. So it's all about you. Thank you.